let me try to share my lecture. So where is my lecture? Share. So can you see this lecture?
Yes.
Yes, very nice.
Okay. So let me talk about this topic, which is a very specific topic in this whole context of this complex issue of congenital scoliosis. As it has been said just as last sentence, I start with exactly this sentence. I think the early detection and the treatment is very crucial for preventing severe spinal deformities, because the severity may change with the growth. So the growth is a fundamental issue in this whole development of these deformities. And of course, it depends, as we have seen, from the type of the hemivertebra and its location, and whether it's combined with other spinal malformations, and if so, whether it's symmetrical or asymmetrical malformation, and whether it's combined with kyphosis. This again is another issue. So how can I advance this? Let me see. So it is very important to do a proper preoperative evaluation to differentiate the different problems we have in this pathology. So the plane radiographs are still there, specifically to judge about the balance of the spine, and including the bending and traction pictures. For me, the traction is more important than the bending, because the bending has different is submitted to different problems like own muscle activities, whereas when you really do traction films, you can see how the spine can develop when you take the load away from the spine. And then it's, of course, this 3D reconstruction of the CT is very fundamental today, as we have seen, and I will show again for the preparation of the surgery and the execution of the surgery. And today there is a debate whether you don't need any more CT scans, because of course this is irradiation, and whether you can do that all with the MRI, and because you need an MRI to exclude intraspinal pathology like syringomyelia, tensor cord, hematomyelia, and so on. So the question is, do we need the CT? Can we not do everything with the MRI, which also delivers the information about the intraspinal issues? So we have to be very well prepared when we go into the surgery. And until now, what we do is we use the CT scan. And what is the crucial issue in the anatomy is to understand that the AP view and the posterior view can be very different. So if you address an issue with surgery, you have to be clear what you're really addressing. It has been shown before by a colleague that, that the combination is sometimes very strange between the anterior perception of the malformation and the posterior perception of the malformation. And of course, you can use the CT scan to really plan the surgery. Like in architecture, you can measure the screw length, you can measure the screw size, and so on. So you can make a surgical plan with that. Here, just to emphasize that you have to be clear that the anterior appearance, what you see when you look from the front to the spine, and when you look from the back, and in the surgery, you go from the back for this specific problem, they may be different pictures. As you can see, for instance, in this part above, where you have, I tried to get this rid. Oh, excuse me, now I have done a big mistake. Ooh, I wanted to make my picture better, but now I have done something wrong. I don't know what the hell I have done now. Let me do this. So I don't know why my screen. So yes. So as you can see here in this in the right upper corner, you have a posterior malformation, which is a complex one. It is a fusion between the transverse processes, but also partially from the ribs. And anteriorly, you have very nicely a hemivertebra, and you think it's a straightforward issue. So you have to be careful when you analyze this X-rays. And I don't know why I cannot advance this. What do I do wrong here? So, yeah. So the indications depends, of course, what the classification is, as we have seen. So the classical indication is the so-called single segmental hemivertebra, which usually is treated between 18 months and 4 years. We always say it should be done before the age of 5. And we have to be aware that this can be anywhere in the spine. It can be at several places at the same time, multiple, it can be combined. So, of course, the most simple one is one in the lumbar or in the thoracolumbar spine, as an example here. And you see that the preoperative planning and imaging is very important. So you see here a case of a 8-year-old girl, which has not been detected before. She came with this problem and with a certain imbalance. And she had on the X-ray, she had a hemivertebra, and here a little bit magnifica, a little bit more bigger. You can see it here. And you see the MRI, and in the MRI, you can already see that this malformation is a little bit more complex than just a simple hemivertebra, because it's combined with a kyphosis and with other malformations of the adjacent vertebra. So we have to figure out which one of these vertebrae is responsible for the deformity. So this is the CT reconstruction, where we try to identify the possible insertion points for the pedicle screws when we want to keep the whole surgery limited to this localized problem. And you can see here the deformity with the kyphosis of this vertebra, which is also malformed. And here you see an unsegmented hemivertebra. And so this is a combination between these two things. So I think the surgery here cannot just be localized to this and this. It has to be including at least 2 segments above and below. So here you can see the possible screw insertions. And at the end, that's what we did, which came out. It was a short fixation relatively, including 2 mobile segments, but basically pretty well balancing the spine in the AP view, but also in the sagittal view, just by a localized procedure with a partial resection of the hemivertebra and some osteotomies in the back. Now, the resection of the hemivertebra, this is a technical standardized issue. I think you have to identify the pedicle which one you want to resect, and you have to isolate it by cutting down the transverse processes and partially the ribs sometimes. And you may use some sort of like a ponte osteotomy of the lamina to free this vertebra, to isolate the pedicle. You can use, of course, the conventional kerisons, rongeurs, or microdrills. Some people today, they use ultrasonic scalpel. We don't use that. Once you have the canal open, you have to identify the relationship between the nerve root and the dura to the pedicle you want to resect. And of course, you use all kinds of tools to make the blood loss as minimal as possible. This can, if you go fast and you don't really look exactly, give attention to the vascularization, this can create pretty strong bleeding, and you can control the bleeding with different tools, of course, with bipolar cauterization when you have isolated the vessel, but you need some other tools like the neuropathies to identify exactly the bleeding points. And when the pedicle once is isolated and resected in the superficially, you can excavate the pedicle either, or you can cut it down. We sometimes use a shank screw just to open the pedicle, and then we can go with a curette into the pedicle and already start to excavate the vertebra, the hemivertebra, because then the neurostructures are preserved. You are not in contact with the neurostructures, and once you have finished this process, you can take down the cortical wall of the pedicle systematically down to the vertebral body posterior wall, and you can go still you can use the posterior wall to protect the dural sac before you really finally open the whole segment, and you resect the end plates, or you freshen the end plates, and to place rods when you have done that. So the thing is, of course, that you may need in unstable situations, so-called unstable situation, you may need at least one rod to put already at the beginning, just to make sure that this segment is not moving around when you are decompressing it. So the realignment, then you do, of course, with today mostly you do that with rod and screws. You can use in very small children, you can use lateral mass screws from the cervical spine system when you don't have a pediatric spine system. You may use additional hooks or screws just to unload this, the major fixation when you do the correction. So you can distribute the force on different implants, and therefore you may prevent the loosening out of the screws before you even finish the surgery. It is clear today that most people use screws, but in fact, you could theoretically also, and we have also done that in situations where there were no implants available. You can do the whole resection, and then you can basically correct manually the patient and put the patient in a cast. You can use also sublaminar wirings or tapes and hooks, but usually with this technique, you cannot limit the whole surgery on one or two segments. You have to include more segments than just one or two. And once you have done the resection, you have removed the hemivertebra, then you have to put the rods. You can pre-bend the rods into the kyphosis, and then you can rotate the rod out of the kyphosis, and you can create a lordosis to correct also the kyphosis. You can use distraction on the convex side, on the concave side, and you can use compression on the convex side. So you can combine these different maneuvers, and you can even use the table. You can breach the table to basically try to correct specifically when it is kyphotic. You can correct the kyphosis by bending the table. Also, operatively, in most of the very small children, you give, at least we do a cast, just to prevent any secondary problem, because they're moving uncontrolled. Or you can, in the older children, you can use a brace, and usually this goes for 2 to 6 months, and then you can deliberate these children. There are complications, of course, and all the complications which exist in spine surgery, and most prominent, of course, during the surgery is the neurovascular complication, or the complication of the dura, of the dural sac. And of course, the postoperative complications are mostly infection, sequelae from blood loss, ileus, pancreatitis, pneumonia, And in a longer term, it's loss of fixation. It may be a pedicle fracture, implant failure, and so on, and the secondary malalignment or non-union. So I think when you look in the literature, you can see that the complication rate in series, and I have put some here, you can see that the complication rate is usually below 10%. The biggest complication rate, in fact, has the group of harms, but I assume they have a very complex pathology, and I think it's a little bit a mixed pathology, so it's very difficult to say whether they all talk about the same thing when they talk about complications. So you don't need a lot of rehabilitation in the children. You may use some physical therapy, but normally they gradually return to their activities. Children feel better than adults what they can do and what they cannot do in general. I think you need the pain management, which is again in children not a big issue. It's just immediately post-operative. You have to monitor for complications, and you have to do a radiological follow-up. Usually we do 3, 6, 12, and 24 months post-operatively. If the patient has no clinical reasons, we avoid X-rays in the meantime, just to see what is happening, because these kids, they get enough irradiation by their with spinal deformity, so you should avoid to do too many X-rays. Only when there is justified clinically you can do it, you should do it, of course. If you talk about outcome, a positive outcome is when you improve the spinal alignment, when you reduce the progression of the scoliosis, and when you improve the quality of life. And you have, of course, complications, as we mentioned before. And one of the major problems is certainly a residual or recurrent deformity, because you have addressed maybe the deformity or the malformation not completely, or you have overseen an adjacent deformity. So this is usually the major issue. Here is an example of a patient where we did some years ago, maybe 3 or so years before we have seen her in this condition. We did a resection of the ribs. She had significant rib fusions on the concave side. We interrupted the bar, the posterior bar, and we did not address, in fact, this hemivertebra, what you can see on the convex side. We believed that the growth may finally balance that, because this is quite a big hemivertebra. But of course, we were wrong, and we had to finally, we realized that this ribs, they refused again, and posteriorly it was refusing again. So we had to do again an intervention where we resected the hemivertebra, as you can see here, and we had to choose a longer fixation. We had to do distraction compression depending on the site, and that's the postoperative result in this in this girl. She's doing pretty well, and she's quite happy about her body position she has. There are some other clinical examples which I may very quickly show. There is here, for instance, a so-called classical hemivertebra in a 10-year-old boy. And you can already see in the simple X-ray that there is also a significant kyphosis, a malformation also in the sagittal plane. And when you look at the CT reconstruction, you can see, depending where you cut, you can see different pathologies. And I think you have to identify which is the major pathology to create this deformity, to create a kyphosis and a scoliosis. And I think it probably, the procedure consists of partial resection posteriorly and the resection of the hemivertebra. So if you want to be sure that you are going to do the right thing, you have very early on in the surgical procedure, you have to identify the hemivertebra, which you believe is the cause of the scoliosis, and you have to mark it. So your incision or your preparation may depend on that. You may do a wrong preparation because from the back, the deformity looks different. The malformation may be a mixed one, so you have posterior elements which are included in this malformation. So to be sure that you will get to the hemivertebra, I think you have to mark it very early on, so you can go there where this problem lies. As you can see here, at the end, this patient could be treated with a bisegmental fixation with simple screws and a brace postoperatively, as you can see here, with a satisfying result. So there are also complex issues like this one. We have operated this girl with a so-called hemivertebra resection, which was obviously incomplete. You can see that she was 10 years old when we operated on her in 2017. And only 3 years later, she has 40 degrees, so she continued to progress with the curve. And in 2024, she had 52 degrees, so she had a significant also rib hump in the meantime. She was 17, and she was very unhappy with her body appearance, and she basically wanted to have another surgery, which is, I think, justified, and that's what we did. We had to take the metal down, and we had to do some posterior resection and realignment of the spine with this result of 16 degrees. So in conclusion, posterior hemivertebral resection is a critical surgical intervention for correcting congenital scoliosis caused by hemivertebra. So it's a very limited issue in this kind of deformity surgery. And it is very important that there is a very precise planning and early intervention and a comprehensive care of these patients. Unfortunately, many of these patients we see too late because they are referred from somewhere else where they have been followed for a longer time without doing a surgery or a treatment. This is just a paper. I think it's an interesting paper. As a reference, there are many references. You know, you can go on Google Scholar and you will have XREM references. It's not anymore necessary to list that all here. But this is a paper which reviewed 23 patients with in a mean age of about 3.5 years. And they had a blood loss average of 210 milliliters. And they had a hospitalization time for 4 days only, and they had only 3 complications. And this has been done in a country where they don't have all the technology available like in the industrialized countries. They have done most of this surgery for the small children with lateral mass screws from the cervical spine, and they showed that the results are as good as the results you get with so-called pediatric spine systems. So thank you very much. This is what I have to say for this. Are any questions, any remarks here? Yes, I hear, but I don't hear anything. No questions, no remarks?
They write to the chat box.
Sorry?
In chat, Professor Aebi, questions.
There are questions here. So, presentation. Yeah, so where should we start? So let's start with the...
Erusalam Banti, the first question. Erusalam Banti.
Yes. So it's an amazing presentation. I think this relates to your presentation, or how young is the youngest patient you have operated? So I can only talk for myself. The youngest is 3 years, what we operated. But some people even operate these patients earlier, but I have not done that. So the youngest patient I operate is about 3 years old. But I think if you have the right equipment, you have the right anesthesia, you have the right support from all the infrastructure of the hospital, you can certainly go with younger patients. I don't know how you handle that. Is this question answered? So what is the next question? Next question is, what is your experience about these deformities are flexible or rigid? Which one is high rate, even has congenital bar? So in my experience, the most rigid ones are the ones which have posterior bars. I don't know whether you have the same experience. If you have just isolated hemivertebras, you may still have some mobility, but as I said, and I think you said that too, many of the so-called simple hemivertebra are not simple hemivertebra. They are very often combined with other malformations. So the flexibility of the malformation, which is the source of the scoliosis, is usually limited. The flexibility above and below, that means in the compensatory curves, this may be completely intact. This may be, and that's the reason why I think you should do traction films, before you do the surgery. Is this question answered? Then there is another question. Is there a relationship between Chiari malformation and scoliosis? Does it have an effect on progression? I think, again, in my experience, a Chiari malformation, an isolated Chiari malformation, is very rare. It's very often combined with other malformations. And so it's very difficult to say whether the Chiari malformation is really the cause of the scoliosis. I think the cause of the scoliosis, if it has a scoliosis, is usually in malformation which are in combination with the Chiari malformation. Any other ideas about what do you think about this? Yeah.
Or I wanted to say one thing with rigid, flexible or rigid congenital bar. This is rigid because the bar make the rigid area and there is no flexion in this area, and we need to make resections at the same time to hemivertebra and to the bar at the same time. The other one is the relationship between Chiari malformation and scoliosis. Yes, there is an argument this issue because in Chiari malformation, patients get starting to scoliosis because of the sometimes inverted cord like this, and there is a relations. Some others supports these things, but there is no high levels. I know.
Yes. Then we have another question: how often do you employ robots during the surgery of congenital scoliosis? So who is using robots? I'm not using robots. I'm probably too old for that. But I think robots, you can apply robots when you really know how surgery goes. I mean, if people start to use robots and they have never done really the surgery, I don't think this is very promising for the future,
Maybe navigation have to do us, but we use freehand techniques. But robot is too difficult to put because this pedicle is again anomaly. Vertebra has anomaly. There is no directions. Pedicles trajectory is different each levels, and find hemivertebra, it isn't easy. We take a lot of fluoroscopy sometimes. I think nobody use robot for this case.
No, I agree with that, and I'm, you know, maybe everybody's talking about artificial intelligence now, and maybe you can program all this much better in the future. But I don't know. I have my doubts about that. If you have a problem, a complication, you know, then the robot probably will not solve the complication immediately. So I think if somebody wants to go in this kind of surgery and do this surgery, I think you have to really deal with this problem, and you have to understand the anatomy. You have to do anatomical dissections so you understand exactly where you can go in the canal, what you can resect, and so on. So I think we are still away from a reasonable use from robotics, and whether this will be the case or not one day, I don't really know. So then there is a question here. Thank you. What is your opinion on placing an autograft or any cage for? Yeah, I forgot to say that. You know, there are more people now, they think when they do the resection of the hemivertebra, they put something anteriorly between the vertebra above and below, like a cage or a graft or whatever. I never do that. I don't see why I should put a cage that costs money for nothing. If you do a proper freshening of the end plates, and you do and you correct the kyphosis by the posterior tension banding system, I don't think you need anything in the front. If you have a lot of bone left from your decompression, you can mill this bone and you can stuff it down if you want into the defect. But I think this is not the crucial element. The crucial element is to freshen the bone, so the surfaces which come in contact with each other, they can heal like a fracture, and you stabilize it in a stable way under compression, you know. I don't know, is any comment about that or other opinion? Please then tell it. What do I have here? Do you often use bracing same as idiopathic? No. So, you know, when you have a congenital scoliosis with a malformation of the vertebra, with a structural malformation, I think the brace is more or less useless. I think you should not do that, or there are reasons. There may be some medical reason because the patient has other problems, the patient has cardiac malformations or whatever. But if the patient is able to be operated, I think it's a waste of time to try with the brace. I think the brace, yes, post-operatively we use brace just to protect the surgery for a while, but not for patients who have a clear congenital scoliosis. I think this is not the area for a brace. You have the same opinion, or you have different opinion?
I do like to bring up, sorry, it's Mike Falloon. I do like to bring up that sometimes when you've had a short segment congenital fusion, bracing is very helpful with trying to control those compensatory curves and maybe shortening a later fusion as they get older and you've already addressed the problem.
So if I understand you right, you think that you can, in a congenital deformity, you can control the adjacent curves? I agree.
I'm saying if, you know, there's so many congenitals that have compensatory curves develop much later.
Yeah.
Then I do believe the bracing of those curves to try and get them a little older for shorter segment fusions in the future, not for the congenital, but rather for controlling their longer term correction.
Yeah, I think this is an option which has to be considered, but I think, you know, if you diagnose a congenital scoliosis on the basis of a malformation, as we discussed it, if you want to give for a long-term solution the patient a chance, and there are no other contraindication. I think probably the most straightforward way is to treat them surgically. But you get patients who have, you know, you have been missed, they have not been operated, and they have compensatory curves. And I think for them this makes sense. And then you may then in the, you know, in the adolescence, maybe when they're 15, 16, you do the final fixation. I agree with that. So what we have more?
Yes, it's finished now.
Sorry, I didn't.
It's finished. All questions finished now.
So we have answered all the questions. Okay, so we are probably already in a little bit